Ma'am, is the screen viewable form? Can you view the screen slide, ma'am?
Yes, it is visible.
Yeah.
Ma'am, we are not seeing the slide, but we are seeing your folder with videos and the PPT.
Yes. Yes, sir. Can you see it now, sir?
Yes, ma'am. Yes.
It is very interesting to speak on a topic, very privileged and esteemed to have the team members for us. The fifth vital sign. The first breath. I feel there would have been a lot of fight and flight reaction as the baby comes through the birth canal. The baby is born, pain is born. This is my perception. The first cry of the baby, lot of struggles. I feel there would have been some sort of pain, maybe some challenges, some stress and strain, which helps to fit into the extra-uterine life. So the first breath till the last breath, that is to the end of life, any human would have to experience this pain. Then here comes what is the pain experience in case of a palliative care setting. The crisp of a presentation today will be how the pain experiences inside the patient. What are the pain management strategies as a health professional at the bedside of a patient with so much of empathy and concern? As a nurse or any team member, a professional, what is that I'm doing? What best I can do for my patient? The first start of our session will be opened up by Madam Pramila. She will now explain us about the pain physio pathways and how the analgesics find its roots to block the pain signals.
When you feel pain, you're not breaking, you're communicating. Pain begins of your body, tiny receptors detecting danger, turning it into electric messages. The body's built-in smoke alarm, no snooze button. In your spinal cord, nerve gates decide which pain signals pass and which get filtered. Pain is not chaos, it's choreography. Your brain decodes pain, deciding how strong it feels and how much it matters. When your brain becomes both the sender and the drama critic, pain isn't just a signal, it's a memory and emotion combined. When the body remembers, so the soul doesn't have to. When pain continues without cause, the message outlives the injury. When your nerves start replaying old trauma like it's a playlist, and when calm returns, the storm quiets. When silence finally feels safe again. That's why we feel pain, not as punishment, but as protection.
Good evening, all participants. Today, we are going to see about pain mechanism, analgesics in pain ladder. Pain. There is a quote which goes as, when you feel pain, you are not breaking, you are communicating. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. It is not a physical sensation, but also it is influenced by psychological, social, and cultural factors. Pain serves as a protective mechanism, alerting the body to injury or disease. It can be classified as acute or chronic. Acute pain is sudden, short-term, and usually related to tissue injury, while chronic persists beyond normal healing time and may become a condition itself. The perception of pain varies from person to person due to differences in pain threshold, past experiences, and emotional state. Effective pain management requires understanding pain mechanisms such as gate control theory helps healthcare professionals provide better assessment and management. Ultimately, it's improving the patient comfort and quality of life. Now, we will move on to the pain mechanism in cancer patients. Cancer pain is a complete multifactorial process caused by both the disease itself and its treatment. The pain is influenced by the following factors, such as there are 6 factors behind this. The number 1 is tumor-related pain. Number 2 is inflammatory mechanism. Number 3 is neuropathic mechanism. Number 4 is treatment-related pain. Number fifth one is central sensitization. 6th one is psychological factors. We'll see one by one. The number 1, tumor-related pain. Here, direct invasion of tissues in bones, nerves, and organs. The compression of nerves, this leads to neuropathic pain. Bone metastasis, this leads to severe deep and somatic pain. Obstruction of hollow organs causes visceral pain. Then move on to the inflammatory mechanism. Here, the tumor cell releases chemical mediators such as prostaglandins, cytokines, bradykinin. These sensitize nociceptors causing increased pain perception to the cancer patients. Third one is the neuropathic mechanism. Here, the damage or compression of the peripheral nerves or spinal cord leads to burning, shooting, electric shock like pain occur. Then move on to the treatment related to pain. Here, maybe due to after chemotherapy, the patient may suffer with peripheral neuropathy. After radiation therapy, they can develop a tissue inflammation or fibrosis. Then surgery pain may be due to postoperative or nerve injury pain. Central sensitization. Here, the persistent stimulation increases excitability of the central nervous system, thus result in amplified and prolonged pain responses. The 6th one is psychological factors. Maybe due to anxiety or depression or fear, there may be a pain perception overall may occur due to total pain. That is because of physical assessment, chemical reactions, emotional and social and spiritual. This concludes total concept of pain. Then we will move on to gate control theory.
How does morphine works? Morphine is a potent painkiller derived from opium poppy. It works by targeting specific receptors, known as opioid receptors. When morphine binds to an opioid receptor, it sets off a cascade of events that disrupt pain signals, travel from site of injury to the brain. Morphine tricks the brain into thinking that the pain is less severe or even non-existent. One way morphine achieves this deception is by reducing the production of pain, transmitting chemical called neurotransmitters. It's like disrupting the supply chain of pain message before they even reach their destination. Moreover, morphine boosts the release of feel-good neurotransmitters like dopamine, which temporarily masks pain with a sense of euphoria. Morphine is not just blocking pain signals, it also tempering the brain's reward system. It has a high rate of addiction. Long-term morphine use can lead to tolerance, meaning higher doses are needed to achieve the same pain-killing effect. It can also lead to dependence, where the body physically relies on the drug function elements.
In gate control theory, as proposed by Ronald Melzerk and Patrick Wall explained, however, our body can turn down pain even when there is a real tissue damage by opening and closing a gate in the spinal cord. Coming to the morphine, morphine is a strong opioid analgesic used for moderate to severe pain, especially in cancer patients. Morphine is the gold standard drug in step 3 of WHO analgesics ladder for severe pain control. For moderate to severe cancer pain, guidelines often recommended strong opioids. There is a pain ladder developed by WHO for cancer pain management. Here, the step 1 mild pain. Here we can give non-opioid analgesics like aspirin, paracetamol, NSAIDs. Step 2, moderate pain. Here we can give weak opioids or non-opioids like tramadol. Step 3, we can give strong opioids like morphine and fentanyl. In cancer, there are many pain trains running all the time. Morphine is like a super strong helper for the gatekeeper. Studies shows that morphine, when dosed correctly, provides adequate pain relief in over 80% of cancer patients with manageable side effects. So, good pain management in oncology is not just about drugs, but about how we use both the patient's own nervous system and pharmacology to keep the gate closed and suffering reduced.
Next part, as sir, you have put a word to look into the case history. So this is a pain in patient, hospitalized patient. How is the patient pain experience? We want to show a simulation which Madam Ali and Jennifer has played. This is the, we have put it as my story, like a case history, which is very self-explanatory from the scenario regarding the pain experience of the score, what you have given us 6 as per the pain scale. And the support system for this patient with carcinoma of the right lung is a financial strain mainly and the psychosocial stress factors. There is severe burning pain and how the pain has been managed. Let us see the simulation.
Good morning, Geethamma. எப்படி இருக்கீங்க இன்னைக்கு? இங்க எனக்கு ரொம்ப சுத்தமா முடியல. கை இங்க இருந்து இது வரைக்கும் ரொம்ப வலியா இருக்கு. என்னால தாங்கவே முடியல சிஸ்டர். எனக்கு அப்படியே இந்த துணி படுறது கூட ரொம்ப எரிச்சலோட சேர்ந்த வலியா இருக்கு. ரொம்ப கஷ்டமா இருக்கு. கஷ்டமா? சரிங்க, உங்களுக்கு நான் வலியை பத்தி சொல்லி கொடுத்துருக்கேன். எந்த லெவல்ல இருக்குன்னு சொல்ல முடியுமா? இப்போ வந்து இப்போதைக்கு நான் சொல்லணும்னா எனக்கு 6 இருக்குங்க. சில நேரம் அது வந்து 10 வரைக்கும் கூட போகும் சிஸ்டர். என்னால இந்த கை ஒண்ணுமே பண்ண முடியாது. ஓ, அந்த அளவுக்கு டார்கெட் பண்ண முடியாம இருக்குங்களா? சரி, இதனால உங்களுக்கு நைட் எல்லாம் தூங்க முடியுதுங்களா இந்த பெயினால? சிஸ்டர், நைட் எல்லாம் தூங்கவே இல்லை. எனக்கு ரொம்ப வலியோட இது போகுமா இல்லையான்ற மாதிரி கவலையா இருக்கு. இல்லையா, அவ்வளவு கஷ்டமா இருக்கு சிஸ்டர். புரியுது, உங்களோட கஷ்டம் எனக்கு தெரியுது. எப்படியான சொல்லிட்டு நான் டாக்டர்கிட்ட பேசிட்டு ஏதாவது அட்ஜஸ்ட்மெண்ட் பண்ணலாமா ட்ரீட் பண்ணிட்டு பார்க்கலாம். சரிங்களா? கழிச்சு நான் டாக்டர்கிட்ட பேசிட்டு சரிங்களா? குட் மார்னிங் சார். மார்னிங் சிஸ்டர். சார், நம்ம கீதா பேஷண்ட் வந்திருக்காங்க சார். சிவியர் செஸ்ட், ரைட் ஷோல்டர் பெயின், சிவியர் பாடிங் சென்சேஷன் வந்திருக்காங்க சார். அப்படிங்களா? சொல்லுங்க சிஸ்டர். சார், அவங்க பெயின் வந்து ரொம்ப சிவியரா இருக்கு. நைட் டிஸ்டர்ப் ஸ்லீப்னு சொல்லிட்டு இருக்காங்க சார். அப்படிங்களா சார்? ஐ திங்க் இது வந்து ஒரு நியூரோபதிக் பெயினா இருக்கும்னு நினைக்கிறேன். மேபி டியூமர் இன்வால்மெண்டா கூட இருக்கலாம். அவங்களுடைய பெயின் ஸ்கில் ஸ்கோர் எவ்வளோன்னு சொல்றீங்களா? 10 out of 10 இருக்கு சார். ஆல்ரெடி 6 டேக்கிங் டேப்லெட் மார்பின் 10 மில்லிகிராம் எவ்ரி 4 hours சார். தென் டேப்லெட் டிசாபோடின் 5 மில்லிகிராம் 2 HS எடுத்துருக்காங்க சார். ஓகேங்க சார். ஐ திங்க் அவங்களுக்கு ஆப்பியாட்ஸ் வந்து டோசேஜ் இன்க்ரீஸ் பண்ணணும்னு நினைக்கிறேங்க சார். அட்வான்ஸ் can we go for advanced therapy sir? Sister, we can do one thing. ஓகேங்களா? மார்பின் டோஸ் வந்து இன்க்ரீஸ் பண்ணிக்கலாம். ஓகேங்க சார். தென் we can add tetrabenazine ஆட் பண்ணிக்கலாங்க. சரிங்க சார். and also we can add laxatives also. ஏன்னா மார்பின் இல்லைங்களா? So we can add for laxatives also. Oh yes. If you do sister, they will see the response. Okay sir. Thank you.
So this simulation would have brought in front of our eyes the pain expression in patient, the nurse-patient communication, the dialogues would have put us in a more empathetic phenomenon. And we could also explore the different dimensions of the pain, like the physical, emotional, and the social or the psychosocial dimensions. So with this part of having an understanding or review of about the pain and the patient who is diagnosed with carcinoma, we'd like to take up the next part of the session will be on Dukkha Pratikara. So So it means Vali Nivarana. It means pain management strategies, pain relief measures, how we are going to reduce the pain in the patient. So in this topic, first I would like to start yoga. So yoga is what is this era's health phenomenon. And here I would like to speak on pranayama. So pranayama, if you are interested, I feel like I can, we can make a practice just a few seconds. This is usually the formula base is like, I have picked up one part of it, like breathe in, that is inhalation 5, hold 5 seconds or 5 counts, and exhalation 10 count. I request all of you, please be seated comfortably. Keep your spine very erect. Please close your eyes. And as I say, please get breathe in, breathe out, breathe in, breathe out, breathe in, breathe out. That is very beautiful, all of us doing this pranayama. So what does it does when you do it, help the patient and even the family member to do? It helps to reduce or block the perception of the pain, reduce the intensity of the pain. The very magic of this pranayama here is it activates the parasympathetic nervous system, which gives you more relaxing response. So this is very, very important, we felt as a team, like as a regular practice base, when our patients and family members do it, it is going to also act as a proactive way to face the pain, to challenge the pain, and convert this pain into a pleasant uh, uh, experience. The next part of the Dukkha Pratikara is life review therapy. Again, we want to show a simulation, and this simulation we are prepared in the mother tongue because pain is more expressed in the mother tongue. I hope this simulation video will help you to grasp a few aspects of the therapy.
அவன் அம்மா கூட சொன்னாங்க நிறைய காலேஜ் டைம்ல மருத்துவ போயிருக்காங்க நல்லா ஹெல்பிங் ஆகிட்டு புரியுது சொன்னாங்க கேட்கறப்பே ரொம்ப சந்தோஷமா இருந்துச்சு அதே மாதிரி ஏதாவது ஃப்ரெண்ட்ஸோட போன ஜாலியாக போனது ஏதாவது ஞாபகம் இருக்காங்க எல்லாமே ஜாலியாக போனோம் பட் ஒண்ணு ஒண்ணு என்ன அப்படின்னா ஒரு தடவை என் ஃப்ரெண்ட் சடனா பேங்க் போயிட்டு அப்படின்ற மாதிரி ஒரு கதை நான் வந்து அவனை ஹெல்ப் பண்ணி அந்த வாட்டர் அதுதான் எப்போ என் ஃப்ரெண்ட்ஸ் எனக்கு சொன்னா போகும்போது டீப்பா காப்பாற்றினா அப்படின்னு ரொம்ப சொல்லிட்டே இருப்பாங்க ஓல்டா என்ன சிஸ்டர் என்ன ஓல்டா இந்த டிசிஷன் அந்த மாதிரி கணிச்சு போறாது கம்ப்ளீட்டா நம்ம வந்து ட்ரீட் பண்ணி எடுத்துட்டு பேமெண்ட் எடுத்து முடிச்சிருக்கோம் நீங்க வந்து அதே மாதிரி பழைய இருக்கும் இவ்வளவு பாசிட்டிவா நிறைய விஷயம் பண்ணிருக்கீங்க பக்கத்துல அம்மா அப்பா வர சொல்லி சொல்லி ரொம்ப சந்தோஷப்பட்டாங்க வாழ்க்கை ரொம்ப இருந்துச்சு அந்த மாதிரி நீங்க நினைச்சு சரிங்களா சரி நான் சார் டயட் மட்டும் நான் கண்டிப்பா மாற்றி சொல்லிட்டேன் நல்லா ரெஸ்ட் எடுங்க சாப்பிட்டேன் சரி தேங்க்யூ.
So, good afternoon to all. Myself Nivetha from PhD College of Nursing. In this topic, it's a life review therapy. The life review therapy, it's a main aim to the patient to support the psychosocially and emotionally well-being. And also, it mainly promotes the psychological resilience. You know what is the psychological resilience? So psychological resilience, it means the person ability to adapt, cope, and recover from their trauma. So mainly in the cancer patient, palliative patients, they think as the past previous life, how they are identified, and the thing they are forget. Currently, what they diagnose, that is only they suitable in their mind. So from this, we have to main focus to overcome the disease, only the previously how they is identified, that is the aspects only. The person think their life it's a more meaningful, and we give a positive emotion towards entire life, and he or she may feel valued themselves, and we give a value reinforce personal identity beyond their disease. And also it's provide a spiritual comfort and acceptance to the patients. Next, we are move on to the climate changes in the life. Why the climate changes in the palliative patient? It means the palliative care patients will be admitted in the hospital for the chronic time period. So while giving in the same room and same kind of environment, the patient feel like as a more stressed, worried, and also in a shallow. So when we are giving the different kind of climates, it may change the patient feel like as an relaxed, and the natural environment like greeny, sunlight, and calm visual environment will give the patient, it will help the patient brain to relax. Mainly, it reduces the brain signal, pain signal. Like the patient think as in a pain, like in a pain in a less feel. So stress environment may give a high level of pain intensity. So we are changing the environment in the pleasant environment. It reduces the stress hormone like cortisol. It reduces the cortisol level. It's indirectly reducing the stress pain. Next, it's we are providing a new surroundings like natural theme colors visualization will shift the focusing on the away from the pain. So it main focus less attention, so less discomfort. Giving the positive environment to enhancing the well-being, emotional well-being, and increasing the coping ability. Though, so at the end, the patient can pain it's manageable. The only thing will consideration to ensure the infection control and no allergen products to be in the patient's room. Next, we will move on to the walkthrough.
We just had a creative thought like, can we have a walkthrough in our palliative care setting, like where we can blend nature and music. So this can be instrumental music as well as the natural sounds and voices and even some sort of noise from the bird's side, which would be more soothing for the patient's mind. So this, what it can do for the patient's brain is it can shift the attention of the patient from the pain. It can again reduce the perception and reduce the intensity of the pain. It can reduce the anxiety level of the patient during pain or even before the patient anticipates that he may get a severe pain. So overall, this walkthrough can support for a better emotional well-being of a patient. So this sort of option in a setting would probably support not only the patient, but the family who may accompany the patient for a walk through in this nature blended environment. Next, I call upon Madam Mudita to share her thoughts on aromatherapy and its evidence-based practice for.
Good evening, everyone. So today I will talk about aromatherapy. You can hear me? Hello. Hello. Am I audible?
Yes, ma'am, it's audible.
So today I will be sharing about aromatherapy, which is actually aromatherapy has been in use for more than 6,000 years. So old because in Greek civilization in India and Ayurvedic, we have been using smell as a therapy for calming and for insight and even for pain. Like till today, we use oil for our toothaches. So actually, aromatherapy has been in practice for a long time, but it got this
Excuse me,
term.
ma'am. Excuse me. Can you please speak in a louder tone, ma'am? Because I feel the voice goes inside sometimes. Or can you please speak louder, ma'am?
Yeah.
Yes, yes.
Am I audible now?
Yes, ma'am. Yes.
So this name aromatherapy has come in, like this term has been coined in 1945. Mr. Rennie Morris. So after that, we started calling it aromatherapy, and we use different kinds of oils, but they are not used like they have to be used with so hello. Hello. Can you hear me?
Ma'am, I think you're a little far away from your mic. If you can just come close to your mic and speak, that will be. Are you using any headphones or are you?
Yes, sir. I am using a headphone. But I
Uh,
don't know. Maybe
you can
it's
keep the
actually.
mic close to your mouth so that we are able to hear you well.
So should I start again or was I?
No, you can carry on, ma'am. We were able to hear you, but it was difficult to comprehend. So if you can just keep the mic close to your mouth, that will be good.
So introduction to aromatherapy. definition of aromatherapy is therapeutic use of concentrated essential oils extracted from plants to improve physical and emotional
Ma'am,
well-being.
ma'am, sorry.
Uh,
We are not able to clearly hear you. Can you try without your earphone, directly speaking to the laptop? Is it possible?
Hello.
Yes, yes.
Uh, now can you hear me?
Yeah, now a lot better. Please go ahead.
So, introduction to aromatherapy, the therapeutic use of concentrated essential oils extracted from plants to improve physical and emotional well-being. So basically, aromatherapy means that we use an extraction from the oil from the plants, some seeds or flowers that oil is used, and this has been in use for more than 6,000 years. And the name aromatherapy was coined by Mr. Rene Morris in 1930. So, uh, second slide.
Ma'am, who's sharing? Who was sharing the slide?
Huh? Hello.
Ma'am, yes, please. It has started again.
So the mechanism of the essential oils is mechanism of action is inhalation. The scents stimulate the olfactory system, sending signals to the brain, essential emotional centers. The oil and the second one is absorption. So oils can penetrate the skin during massage to enter the bloodstream and interact with local receptors. The role in pain acts as a complementary therapy alongside traditional medicine to reduce perceived pain levels. Slide. Common essential oils for pain relief. Lavender, calming effects that reduce muscle tension and help manage pain after surgeries. Peppermint contains menthol, which provides a cooling sensation and acts as a natural analgesic for headaches and muscle soreness. Eucalyptus, well known for anti-inflammatory properties, effective for joint pain, especially in cases like arthritis. Ginger provides a warming sensation that eases joint pain and improves mobility in older adults with back issues. Next slide. Common application techniques. Direct inhalation using a diffuser or inhaling directly from a cloth to impact the nervous system quickly. Second is topical massage, diluting essential oils with a carrier oil like coconut or jojoba and massaging into the affected area to improve circulation and reduce inflammation. Then there is therapeutic baths, adding a few drops of oil to warm bath water for full body relaxation and relief from general aches, and compresses, applying a warm or cold cloth soaked in diluted oils to specific localized pain points. Research evidence and benefits. Clinical efficacy meta-analysis shows a significant positive effect in reducing pain intensity on the visual analog scale. Specific conditions, strongest results found in managing post-operative pain and obstetric or gynecological pain. Secondary benefits, aromatherapy also helps reduce related symptoms such as anxiety and stress, nausea, vomiting, and it also improves sleep quality. Safety and best practices. Dilution is key. Never apply neat, that is undiluted essential oil directly to the skin. Always use a carrier. Then, before starting any oil, always perform a small skin test first to check for allergic reaction or irritation. Contraindications. Use caution or avoid certain oils during pregnancy or for individuals with high blood pressure or epilepsy. Consultation. Speak with a healthcare professional before starting aromatherapy, especially for chronic conditions.
So, good afternoon, everyone. I'm Ms. Sandhya from PhD College of Nursing. So, can you visualize this doll? So, this is one of the approach or a therapy which is followed by certain practitioners from the ancient period. From the audience, is there any
Anna, are you able to hear them?
No, sir, it got stuck actually.
Okay.
Maybe their
Probably.
network issue. We can wait for a few minutes, sir.
Yes. If you have phone number, will you be able to reach out to them, inform them? Yeah.
Yeah.
Yeah,
Okay.
completely disconnected.
Okay, sir. Nivedita, ma'am, are you facing any issues?
Yes, ma'am. Yes, ma'am. There is a network issues. 2 minutes, ma'am.
Okay, done.
So, as this healing touch, it was not a new concept. It was first practiced by Florence Nightingale in the ancient period during her caring during the patient time. And now in the modern era also, there are many clinics, even in our Coimbatore, like in Kuniyamuttur, some places they have mentioned. So it is not only the role of nurse, it is the role of doctor and the collaborative team members who are entirely going to take care of the palliative patients. So it was later on in the year of 1989 in USA, a Northern American nurse who is Janet mentioned. He is a registered nurse who has completed his Bachelor of Science in Nursing. He has he has developed more research topics on healing touch, and he has furthermore given the benefits by its effective method by practicing it on the patients regularly. And he believes the concept as by touching the patient or giving a vibration to the patient, it creates a positive energy field. So that energy field will try to reduce the patient's pain and also the patient's anxiety and the patient's stress. So overall, complete effectiveness will be maintained by following the healing touch technique. So this is one of the new approach that can be easily applicable for all the patients who are having pain as well as stress and as well as anxiety.
As I peeped on the third day of my duty into the palliative ward, I could see a patient. Just on a conversation with the patient, I was trying to actively listen to the patient's wishes. Dream. So it was like at least once in his lifetime, he wants to see Abdul Kalam Aya, to speak few words to Abdul Kalam sir. This cannot happen in reality, but electronically, a thought which can instill more a pleasant memory in the patient and a euphoric effect to the patient and family.
Dreams are not what you see in sleep. They are the things that do not let you sleep.
So this was a thought which can support the patient to get an euphoric effect, and also the family will be emotionally boosted up to see a few wish of the patient which we can make come true, which can work proactively for the pain reduction. The next part of our session, pain is not only my story, it's the story of my family. We can just observe this simulation scenario.
அப்படியா அம்மா எனக்கு இதுல கை ஷோல்டர்ல இருந்து கை வரைக்கும் ரொம்ப எரிச்சலோட அப்படியே படுறது அப்படியே இந்த துணி மேல படுறதே ரொம்ப உறுத்தலா ரொம்ப டென்ஷன் ஆகி போல ரொம்ப செலவு இருக்கா ஒரு வேலைக்கு போறது இல்ல அதே மாதிரி எனக்கு இந்த வலியும் என்னை கொடுத்தது இல்ல எனக்கு வந்து நான் எப்படி சமாளிக்கிறாரு குழந்தைங்களை வேலைக்கு போகிறதுனால வீட்டுக்கும் செலவு பண்றதுக்கும் ரொம்ப கஷ்டமா இருக்கா எல்லாமே சேர்த்து நைட்டெல்லாம் தூக்கம் வர மாட்டேங்குது வலி ரொம்ப அதை விட எனக்கு ரொம்ப பாடாப்படுத்திருக்கான் அவனோட கூட இருக்கு பார்த்துட்டு தான் இருக்கேன் உனக்கு வலியும் தீர்ந்த பாடல உனக்கு டென்ஷனும் அதிகமாயிட்டே இருக்கு ஒரு நாளுக்கு ஒரு நாள் பாக்கலாம் நம்ம காலையில நம்ம சிஸ்டர் கிட்ட சொல்றோம் அவங்க வந்துட்டு டாக்டர்ஸ் கிட்ட பேசிட்டு இதுக்கு ஒரு முடிவு இருக்குது இது நம்ம வந்து கண்டிப்பா ஏதாவது பிரச்சனையை வந்து ஈஸியா ஹேண்டில் பண்றதுக்கு நிறைய விஷயங்கள்லாம் இருக்குதுன்னு சொன்னாங்க பாப்பா அவங்க வந்து நமக்கு ஏதாவது ஒரு நம்பிக்கையான வார்த்தையை நமக்கு சொல்லுவாங்க நான் கண்டிப்பா நம்புறேன் இதுக்கு ஒரு முடிவு இருக்குதா நீ கவலைப்படாத டென்ஷன் ஆகாத சரியா எங்க சிஸ்டர் தான் வந்துட்டு இருக்காங்கன்னு தோணுது சரியா நீ கவலைப்படாத சிஸ்டர் சொல்லுங்க சிஸ்டர் நான் கிட்ட பேசிட்டா உங்களோட பெயின் எல்லாம் எக்ஸ்பிளைன் பண்ணிட்டேன் என்ன பண்ணிட்டு எவ்வளவு பெயின் சொன்னது எல்லாத்தையுமே நான் பார்த்து சொல்லிட்டேன் அவர் வந்து நான் கிடைக்கிற ட்ரீட்மெண்ட் அட்ஜஸ்ட் சொல்லி சொல்லியிருக்காரு அது மட்டும் இல்ல ஏன்னா உங்களுக்கு உடல்ரீதியாவும் கஷ்டப்பட்டு இருக்கீங்க பண செலவுலையும் கஷ்டப்படுறீங்க பண பொருளாதாரத்துலயும் ரொம்ப கஷ்டப்படுறதுனால உங்களுக்கு சோசியல் ஒர்க்கை அரேஞ்ச் பண்ணி சொல்லியிருக்கேன் ஸோ நீங்க தமிழ் பயன்படுத்தா இந்த மாதிரி கஷ்டப்படுறது வந்து உடல் சேர்க்கும் அவருக்கு வந்து நம்ம எல்லாம் ஒரு டீமா இருந்து இந்த மதியில இருந்து கண்டிப்பா ரிலீஃப் ஆயிடலாம் அதுக்கு தகுந்த மாதிரி மெடிக்கேஷன்ஸ் எல்லாம் எடுத்துக்கலாம் சோசியல் ஒர்க்கு உங்களுக்கு என்னெல்லாம் வேணுமோ நாங்க டீமோட எடுத்துக்கலாம் டாக்டர்ஸ் இங்க தனியா ஃபாலோ பண்ணா வந்து நாங்க ரிலீஃப் ஆகி நல்லா ஜாலியா எல்லா பிரச்சனையும் தீர்த்துச்சு கண்டிப்பா ஏன்னா நம்ம எல்லாம் ஒரு டீமோட தான் இருந்து நாங்க பண்ண போறோம் நம்பிக்கையா தனிப்பட்ட முறையில பண்ணாங்க நாங்க டீமோட பண்ணலாம் வழியில இருந்து ரொம்ப சந்தோஷமா இருக்கு நீங்க சொன்ன நம்பிக்கை ரொம்ப நன்றி நல்ல முடிவு சொல்லிருக்கீங்க சிஸ்டர் நல்லபடியா ரொம்ப சந்தோஷம் வழியெல்லாம் ரிலீவ் பண்ணிக்கலாம் சரிங்களா நன்றி
Good afternoon, sir. Why the need of family members involved in this counseling session? Can you say anyone, please? Since not only the patient suffering, but the patient family members also journey from the time of diagnosis. So they also need some sort of relaxation, stress-free environment. So we need to counsel them also. They should know the prognosis, direct, honest, and compassionate language that focus on patient goals, quality of life, and emotional support, and life modification, etc.
So the next session will be Madam Latan Swami on collaborative team approach. Ma'am, the ball is in your court, ma'am. Latan Swami, ma'am. Can we?
Hello.
Yes, ma'am.
Ma'am, can you hear me?
Yes, ma'am, it's audible, ma'am.
Okay, okay. Right. The presentation, collaborative team approach. Thank you so much for this topic. And just
Excuse me, ma'am.
Excuse me, ma'am, your voice is breaking.
Ma'am, it will be better if you turn off
can you
your
hear me now?
video.
Yeah.
So if you can turn off your video, your bandwidth will, for the audio will improve.
Okay. All right. Better now. Is it better now?
Yes, ma'am, it is.
Yes, ma'am.
Okay, you can hear me now, no? All right. Okay, can we reach the slide, please? All right. Okay, so when we look at pain, we're here looking at the total pain, physical, social, psychological, and spiritual pain. And we see in the case of Mrs. Greta also. Can we just change the slide? I will not take so much time in this. Yeah, maybe next slide. Can we go on to the next slide? All right. So when we look at the general principles of pain management, can we go to the next slide, please? All right. When we look into the previous slide, please. Okay. Can we stay here for some time? Okay. When we look into the general principles of pain management, it's quite a complex process. Evaluation, explanation, management, monitoring, attention to details. Definitely, this need the attention of a multiple person. Here, the irony is that each team members, they bring their beautiful, unique skills. Can we go on to the next slide? Okay, so looking into the different methods of pain management, which I will not go so much in detail, modification of pathological process, pharmacological management, non-pharmacological management, psychological management, interruption of pain pathways, modification of way of life and environment. And regarding the modification of pathological process, here, if we look at pathological modification of the pathological process, many healthcare professionals are being involved. Radiotherapies, chemotherapies, hormonal therapies, surgeon, oncologists, nurses, radiologists, where every team has a role. Either they might be trained in palliative care or not trained in palliative care, but they are all being needed. And when we look into the pharmacological management, many people are needed. Just imagining the patient that we see here, she has to take her medicine every 4 hourly. So it's not just the doctors or the nurses or the pharmacists, the family, the caregivers and the family also get tired to remind her about the medication as well. So that is a time that we need the community members, the friends also to be a part of the pharmacological pain management as well. In the previous presentation, we have seen many non-pharmacological management like the yoga, the walkthrough, aromatherapy, the doll therapy, the touch therapies, and here the physical therapies, massage therapies, the heat application, whatever things that we see in this slide as well. Here, I also personally feel that it's not only the medical professionals, even the non-professionals, the musicians, even the beauticians, all of them, they can be a part of the non-pharmacological pain management. What an amazing thing that we have here, right? Singing for the stars, the musicians, the music therapists. These people have no idea, the singers have no idea about the medicine, about the palliative care, but just their evening with the patients and the healthcare providers, they change the patient's mindset. They are contributing a lot to the community. So we have already introduced the musicians to our palliative pain management. What about the other artists as well? The actress, the actors, and all of that. They can be very much help for the pain relief of our patients. Here, yes, interruption of pain pathway. We look at the medical team. It's not necessary that the neurosurgeon is trained in palliative care, but it is also very important that it is very important as a palliative nurse or maybe as a palliative practitioner with all of these healthcare professionals and work with them. Next slide, please. Modification of way of life and environment. Here, when we talk about the walking aid, the wheelchair, the hoist, all this, a simple thing like the walking aids or the wheelchair, like can be a life changer for the patients. And there might have been a richer patients who are able to support their wheelchair and the patient pass away. Why not requesting that particular family to donate the wheelchair for the patients who might not be able to buy in the future? Like we see in the next slide, the social support system, the family working with the non-governmental organization, financial support. And these days, many of the companies, living companies there, why not include them in their pension? Because there's no word in the dictionary of palliative care that I cannot do anything else for you. I might not be able to do anything for the other patients, but why not networking these particular patients to the people who can help them? So it's not doctors or nurses being trained in palliative care, but a huge group of people are involved in need to involve in engagement, the medical social workers, the nutritionists, and even the sweepers can be trained can be trained in recognizing the patients experiencing pain so that they can be attended by the nurses and the volunteers, all of them. And it's a huge team who are involved in the patient's pain management, the physiotherapists, the occupational therapists, and all of it. And I also wanted to add in the slide, which we see in the slide, even the receptions in the hospital can be trained to recognize which patients is in severe pain. So those patients sent to the doctors earlier than the rest of the patients. Even the ward boy that we have, the hospital assistant, all of them can have part of the pain management, not forgetting the leaders, the hospital management. We are happy that these days many of the hospital management are involved in palliative care, but yet there are certain hospitals who have not introduced palliative care in there and who does not have pharmacological treatment for the palliative patient in their hospital. So it's very important that we involve the leaders in the hospitals, in the all of it as well. So I just wanted to conclude that the palliative care personnel, the nurse, doctors, all of us cannot do it on our own. We have to team up with the other healthcare team members and also with the community, because unity is strength. When there is a teamwork and collaboration, wonderful things can be achieved. Thank you so much.
The next session will be on preceptor-preceptee chain. So what is the relationship between the preceptor and preceptee? We'll shortly see through the video.
Wala part ko to siya. But it's our team, no? So I have to be there. Jai tagiwi.
Ma'am, are you sharing the audio as well? Because we are not able to hear the audio part. Nivetha, ma'am,
Yes, sir. Please.
we are
Yes.
not able to hear the audio. You'll have to share the sound while playing the video. Probably it stopped and you restarted, no?
Yes, sir.
So,
Yes.
so please
Just a
check
minute.
it.
Yes.
Yes, please. Ma'am, we are still not able to hear the sound. Are others able to hear, Hannah? No, Niveda, ma'am, we are not able to hear you. I think you have not clicked on the share sound button when you are sharing, no?
Yes, sir. We'll check again, sir.
Yeah, please stop the sharing. When you start, there is a share sound button on the right side. You have to
Okay.
click it.
Yes, sir. Yes, sir.
If not, you will be able to hear the audio. We will not be able to hear.
Yes, sir. Yes. Sorry, audience. So there was some technical issues. I'll explain what was preceptor and preceptee chain. Actually, preceptee was watching the patient. She was taking care of the patient completely, and she was very empathetic on patient care, whether the patient pain is relieving or not. So she was very bothered about patient's pain, because the patient pain has not settled even after giving morphine as per the physician's order. So the preceptor was watching her actions, what was really bothering the preceptee. So thereby the preceptee is when expressing the feelings, what was going on her mind, and it was interrupting her work, other next work like documentation, some other extra routines which has to be followed by the preceptee. So once it has been observed by the preceptor then started assessing what is exactly bothering the preceptee. And after that, once she expressed all her worries, then the preceptor is guiding in such a way that everything will be solved, and we are following the assessment and the nursing care, whatever it is implemented, everything has been explained to the preceptee. After that, it is being explained as the quality of the life will be improved day by day, the care which is given by the nurses and as well as the collaborative team members. So once it has been realized by the preceptee, then she has carried out the work completely. So that was enacted in the video. So the benefits of this preceptor-preceptee relationship is, so among the nurses, the reflective practices and the learning culture will be improved. Emotional heaviness of the new nurses or the preceptee will be replaced with the empathetical care in the future aspects. Then it creates a free space to express fear of handling the patients, even though if they are in a chronic illness. And it creates or guides the preceptees how to handle the patients even in a difficult situation, how to talk with the patient, how to handle and talk with the family members or caregivers of the palliative patients. And it also gives some constructive feedback mechanisms when it is right and when it is wrong, or when the suggestions will be given how to improve. And the documentation purposes also will be explained detailedly through this preceptor-preceptee approach.
The next part of the presentation, I'd like to continue from this part of preceptor-preceptee is the introspection. This is we felt like this is very, very important when a nurse is very much interested to work in a palliative care setting. So not only the beginning nurses, but also even though you get experienced in the field, I think introspection will help us to refine our strategies. Can you see what is this? Can you see what I hold? The first one, self-analysis. I hope you are able to see. This is what is, I'll have to explain. The self-analysis, how you have to do it is, as you complete your care process, you finish off your duty, journaling is very important. Put a diary for yourself. What did you do? What are your exploration? How was your communication with the patient? What good did you do? How did it work? Such sort of journaling. Your observation skills, how much is getting refined each day. How you demonstrated your active listening skills in front of the patient. What is this question of empathy inside you? How are you managing your stress as you're working in this particular area? What are your strengths? One can also go into SWOT analysis, your strengths, your weaknesses, what opportunities, what threats you feel, write it in a note. After writing, what am I going to do? This one is important. Validate. Where should I go? That is, the previous speaker has presented the preceptor, preceptee, chain, or the bonding. So here, when validating, I put here E3, that is emotions, expressions, and expertise. How are your emotions? What expressions played between you and the patient? What insight have you got as a nurse or any healthcare team? And how did it work with an expertise? These would really nurture you and create a very good platform for pain relief measure at the patient site. And this is may not be a perfect checklist. Like as a nurse, I'm interested to have a checklist for my self-analysis. I can have these basic domains and analyze myself every day. And I can also rate myself and see that I reach the point of 24 or 25. The future directions from this topic, evidence-based practice interventions. So evidence-based interventions should come into practice in the palliative care setting, which exists, but still it has to be huge in count. And specific, being a nurse, I would like to touch the nurse's role. We need to extend the whole team's work domain and expand even our students' cognitive domain through training programs to educational classes. And we need to list down how we may be able to reach the younger generation into this palliative care setting. So when we organized a module, I could see in the classroom at the end of the module session, more than half of the class students were more interested, and they would ask a lot of clarifications, and they listed their interest to work in a dedicated way at the bedside of patients in the palliative care setting. So I have put a few riddles. Maybe we can try out. Participants, I request you to try out. I am given when cancer pain runs deep. I soothe the hurt so patients can sleep. But I demand respect or breathe, I may steal. What am I? Maybe a tough one. We'd like to see the answer. So it is morphine. I am given when cancer pain runs, and it takes away my sleep, and it takes away my breath. Okay, so the answer is morphine. Next. I am soft and calm. I ease your pain. I help you feel safe again and again. In cancer care, I am given with love. What am I? It is healing touch. You have seen a demo of heal to touch, touch to heal. Next. I guide with care when pain feels strong. I learn and help as we move along. In cancer care, we work as one. What are we? This is mentor-mentee, or what the simulation we are trying to show the preceptor and preceptee relationships. The presentation will not be a justice to end the presentation without touching this dimension of spirituality. So based on the patient's spiritual practices, the team members, we have to support the patient and family members for this. So this is, as to recall Abdul Kalam sir, the topic given to us is pain. I'm happy and very privileged and to pronounce these meaning what he has given for pain. Positive attitude in negative situations. I think this exactly suits to us who takes care of the one who is suffering with pain and the one family member who is totally taken away negatively by observing and seeing the pain experience in the patient. Our sincere gratitude for giving us a very excellent, a very beautiful topic called the pain. My gratitude to Dr. Rajit, Dr. Deborah from PSG, the main origin of how we are able to undergo this training program. Dr. Terry Mice, I thank you, sir, because we're so comfortable when you gave us the space in the introductory part. You are very patiently allowing us some minutes to wait for how we are going to give you the scenario, what Pallium has given us. And I sincerely thank our PSG management, our Pallium team members, ma'am who has been organizing this session, and the whole of our team members for their excellent effort, hard work, input. By this, I come to conclusion of our presentation, sir.
Am I audible?
Yes, sir.
Okay. Thank you, ma'am. Thank you for you and your team have put together. I should say you have put your heart and soul in, designing the entire content. I'm sorry I couldn't help you out during the preparation stage, but you you have worked hard, I can say, I do record a lot of videos to develop education material. I understand the difficulties in preparing a script and doing a video recording. It is a very tough task, and you have done a wonderful job in doing all those background tasks, you and your team. Thank you for this wonderful presentation. So I see all the videos off. Could you all please open your videos? I see only Niveta ma'am on screen. I know that there are many sitting in that same room. Uh, there are few important carry home messages that I would like to communicate. So could you all open your videos, please? So these are very essential that you need to speak to your students. Okay, one of the things that I would like to very much address is there is a lot of misconceptions regarding morphine. Sadly, some of these things came up during the presentation also. So we would like to discuss and clarify this. So first, good things first. I mean, you have comprehensively presented a lot of non-pharmacological interventions um of that can be used for a patient in managing pain. That is very good. But yesterday or day before yesterday, I had put a message in the WhatsApp group. I wanted you to diagnose this person's pain. Did you? I mean, I believe all of you are there in this group. Did you diagnose this person's pain? What is your diagnosis of this person's pain?
Total pains.
Yes, I mean,
Total
in
pain.
palliative care, we look at pain as total pain, but I want to look at, yeah, I completely agree. Okay, in palliative care, we want to look pain as total pain. It is very right. And we want to look at the physical dimension, psychological dimension, social dimension, spiritual dimension, as proposed by Cicely Saunders. I agree with you, but I want to focus you on physical pain and diagnose the components of physical pain here.
Is it neuropathic pain, sir?
Okay, very good. There is a neuropathic component here, probably a strong neuropathic component here. But I want to go much deeper. What type of neuropathic pain is this person describing? That
Burning.
never, that is a quality of pain. Okay. See, when patient comes to you, they use different words. Okay, குத்துது, கொடையுது, எரிச்சலா இருக்கு, ஷாக் அடிக்கிற மாதிரி இருக்கு. I mean patients, for those from outside Tamil Nadu, patient describe different things about it. It is burning, it is shooting, it is tingling, it is crawling. you know that is quality of pain, but there is a peculiarity with this neuropathic pain that you need to understand. What is that? It was very clear in the given scenario, but never once came during your discussion.
Maybe due to compression of peripheral nerves or damage to the tissues.
That is how a neuropathic pain originates. Typically in carcinoma lung, when the tumor grows in the chest cavity, especially the tumors that grow in the apical region of the lung, usually catches the brachial plexus. Okay, they encapsulate or infiltrate into brachial plexus or just claw over the brachial plexus, and that causes very severe neuropathic pain. I agree, but there is a typical neuropathic pain that this person describes. What is that? Have you heard this
Burning
word?
and radiating.
That is again, that is a quality of pain. Okay, that is how patients describe their pain. Okay, have you heard this term allodynia? What is allodynia?
Yes, sir.
What is allodynia?
Like shock pain, sir. Electric
No, that's
electric
not
shocking pain.
Intractable pain.
No, there are two words in neuropathic pain, or some common presentations of neuropathic pain. One is hyperalgesia, the other one is allodynia. What is the difference between these two? When you see these features, you can be 100% confident that it is neuropathic pain. One is hyperalgesia, the other one is allodynia. What is that? Any idea? Okay, because of lack of time, I'll quickly explain. Hyperalgesia is, there is a painful stimulus, but it is causing more pain. For example, you are examining the patient and then you press over a painful stimulus, okay, or you slightly tap the area, but the patient is responding it as, our patient is experiencing it as much intense pain. Hyperalgesia simply means increased perception of pain. That is hyperalgesia. Now, what is allodynia? Allodynia is a non-painful stimulus causing pain. Something like a touch.
This may be.
Okay. See, when I touch my cheek, okay, what should I experience? A touch sensation, right? Okay. You can touch yourself and see. Okay. When you touch yourself, you experience a touch sensation. But these patients having allodynia, even if you touch that area, they will scream or quickly withdraw in pain. I'll tell you how. See, usually we see many patients in OPD. Patients with carcinoma lung with allodynia features, they will come to OPD. If it is a male, they will come without a shirt. They will be extremely uncomfortable sitting under the fan. Even the breeze of the fan, when it touches the body, they will just wince in pain. Okay, it's a very typical feature of a neuropathic pain. Happens when a tumor is infiltrating into the nerve. Allodynia. Okay, keep in mind. One is hyperalgesia, where there is a painful stimulus, but that painful stimulus is causing more pain. Okay, that is hyperalgesia. It is neuropathic pain. The second feature is allodynia. Allodynia is a non-painful stimulus like touch causing pain. Okay, that is allodynia. So, what feature does this patient have, Geeta? Yeah, she has allodynia. Okay, that is a very important observation. Okay, now that is done. Okay, so allodynia you can see in many cases. Okay, in my experience, I've seen allodynia in patients with CA lung. Okay, it is very interesting. They will come to OPD without shirt. You ask them, okay, they'll say, male patient, they will say, even when the shirt touches my chest, it is intense pain. Okay, they cannot tolerate. Okay, they will sit away from the fan's breeze. Okay. Now, there is something called post-herpetic neuralgia. Have you heard of this post-herpetic neuralgia? Patients with the history of, you know, uh, history of chickenpox. Suddenly, when there is an immunocompromised patient happens, like in cancer treatment or steroid therapy, okay, they will start developing lesions along the nerve border wherever this virus was sitting dormant. Now, due to immunosuppression, it is flaring up. That flaring up, that virus again damages the nerve and they develop very severe neuropathic pain. Along the side of the lesions, if you touch, they will wince in pain. Women having such lesions will find it extremely difficult to wear the blouse or a sari. Okay. They usually come with a nightie or a chudidar. Okay. So that dress doesn't come in contact with those areas. Okay. There are many other situations, but these are the very two common places where you will get to see allodynia. Okay. Now, one thing I found it extremely interesting is you completely omitted pharmacotherapy in neuropathic pain management. Why is that?
We have told morphine, sir.
No, morphine. What is the, how does, morphine, we call it three types of resistance. One is pseudo-resistant, semi-resistant, and completely resistant. In neuropathic pain, morphine is something like a semi-resistant, which means morphine cannot offer full pain relief in neuropathic pain. It can offer only partial pain relief. Okay. If it is a pure nociceptive pain, morphine works like a champ. Okay. It completely blocks nociceptive pain. If it is a neuropathic pain, morphine can give only partial pain relief. You increase the dose, patient will start feeling drowsy, but the pain will be remaining. Okay. That is one of the ways you know that there is a component of pain that I'm missing out, which could be neuropathic in nature. Morphine does not work at all in muscle spasms. Okay, no matter how much morphine that you give, it is completely resistant. Okay, muscle spasms are completely resistant to morphine. You will have to give muscle relaxant. Okay, now morphine works only, or morphine gives only partial pain relief in neuropathic pain. What else you can give? Have you heard of neuropathic pain ladder?
Yes.
Like how you have a WHO analgesic ladder, there is also something called neuropathic pain ladder. Okay. Okay. It is probably this may be too much for your students, but during the scenario that you presented, I think it was Narayana Swami madam who suggested gabapentin to the doctor, right? Right,
Yes,
madam?
Yes,
Okay.
sir.
Gabapentin is part of your neuropathic pain management ladder, but gabapentin is not the first line. Okay. Gabapentin comes somewhere in the second or third step. Okay. When patient comes to us with neuropathic pain, okay, we usually start the patient on a very short course of steroids. Steroids are the first step of neuropathic pain ladder. How do steroids help? We use corticosteroids. How do they help?
Anti-inflammatory.
Sorry?
Anti-inflammatory.
Okay, I agree it is anti-inflammatory, but how does it work? It is a very useful thing to know how steroids work. Okay, I think we don't have much time. See, when there is a tumor, there is something called a peritumor edema. Your body is actively trying to fight against this tumor. So there is always a swelling around the tumor. Okay, and most often it is this swelling that is going and causing compression along with the tumor. It will be compressing the nerve, compressing the blood vessel, infiltrating into the nerve. So when you give steroids, the peritumor edema will shrink. Okay. Thereby you are relieving the compression. And keep in mind, steroids work very fast. You can see a response even with just one dose within a day. Okay. That is why we start the patient on short course of steroids and then switch to neuropathic agents, anti-neuropathic agents. Okay. So first line, we use corticosteroids. Second line, we use antidepressants, preferably tricyclic antidepressant. Any idea? Can you give some examples of tricyclic antidepressant? Okay. Commonly, we use amitriptyline. Okay. Amitriptyline, you don't need such a stronger antidepressant dose to manage neuropathic pain. You usually start at 10 mg HS or 12.5 mg HS and titrate up. All these drugs, for example, your gabapentinoids, amitriptyline, sodium valproate, all of these drugs take time to build up. Okay, so they will not give pain relief immediately. That is why you are starting the person on steroids first, so that patient gets a good pain relief. But steroids, okay, you cannot continue to give. Once you stop steroids, the swelling will come back. So you start the patient on steroids, introduce tricyclic antidepressants, gabapentinoids, and then withdraw the steroids so that patients are comfortable. That is how we manage. Keep in mind, using your WHO analgesic ladder, neuropathic pain ladder, 90% of the patients will get very good pain relief. Okay, 90%. And rest 10 will require some intervention. Okay, either a neuroleptic block or spinal anesthesia, things like that. Okay, so pharmacology is a major chunk of your management of neuropathic pain. You can never overlook it. Okay, imagine you are having a surgery and in the post-op ward, they are not giving you analgesics and only playing music and doing aromatherapy. Will you agree? Will you be happy with that treatment? None of us will be happy, right? Pharmacotherapy is a mainstay for managing, and it should be. I'm not undermining any non-pharmacological therapy. Non-pharmacological therapy should be used as complementary, but not as substitute. Okay. Non-pharmacological therapy do not substitute pharmacotherapy, but they are an addition. And when they are used as an addition, it really improves patient's pain relief. Okay. But not as a sole line. Okay. I'm very happy you covered a lot of non-pharmacological approach. Okay. Many things that we often don't hear about. That is a very good effort. But do not ignore pharmacotherapy. You should teach your students many important things about pharmacotherapy. For example, a patient receiving amitriptyline in the night, what important advice should the nurse give to the patient? If you ignore pharmacotherapy, this will be a consequence of it. Amitriptyline is known to cause postural hypotension, correct? Okay. So you'll have to tell the patient, if you want to go to the toilet in the middle of the night, okay, sit up in the bed.
Accompany the patient attender, and we have to ask them to sit in the bed for just few minutes, then they'll get up from the bed.
Those are very important. Yeah, those are very important advice a nurse should give to the patient. What is very important about steroids administration?
While giving steroids, the patient may develop increased blood sugar.
That is in a long-term use, not just with one dose of steroids, the blood sugars will not shoot up. After some 2-3 doses, we will have to monitor, I agree. See, one of the common mistakes even doctors do about steroids is steroids should always be given before afternoon, preferably as a morning dose and afternoon dose, and it should be stopped. We don't give steroids in the night. What will happen if you give steroids in the night? Patients cannot sleep. See, normally in our circadian rhythm, there is a dip in the steroid level in the night. All the hormones take a dip, especially early in the morning, and then slowly rise back. Okay. It will be very difficult for the patient to sleep if steroids are administered in the night. A nurse should recognize that and plan the dose accordingly. Okay. These are very important things we need to speak to our students, nurses. Okay. So I will encourage you all, read a little bit more about pharmacotherapy. I mean, from all that you presented, you're all experts in non-pharmacological therapy. That is very good. But you also need to read a bit more on pharmacotherapy, specific drugs. For example, madam suggested gabapentin, to be added with morphine. Gabapentin is a very useful drug, very effective drug, but it is not the first line. One of the things problems with gabapentin is that it is costly. Okay, so gabapentin can really bankrupt because these patients will require long-term therapy. Okay, so what happens if you start the patient on gabapentin and they are not able to buy that medicine, they are struggling to afford, you will not be able to go to another drug. Another drug will not work. So when we start with amitriptyline, which is very cheap, and then try if it is helping the patient. If it is helping, we continue. Okay, and when needed, we introduce other drugs. Okay, in a private setup, probably you can directly start on gabapentin, but in a resource limited setting, we'll have to keep the patient in mind. Okay? So these are all the. So basically, we also need to review pharmacotherapy bit more, and then be more confident in teaching. Okay. So overall, a very, very comprehensive presentation, very holistic as well. Oh, sorry, this I'll say about this and finish. TENS. Okay, TENS is a very useful intervention in managing neuropathic pain. Okay, transcutaneous electric nerve stimulation. Okay, it's very, very useful. So read about it. So it is a one very effective non-pharmacological therapy for neuropathic pain. Okay, great. Okay, thank you so much. Thank you for your wonderful presentation, and I sincerely appreciate your efforts in putting this through. Thank you.
Thank you, sir, for your valuable words. We will take up your words. We are really very happy to have you, sir. You have given a very good explanation for each and everything, and you have shown a very good attempt to us, sir. Thank you so much, sir.
Thank you. Thank you so much.
So, thank you. Thank you, sir, for facilitating the session, and thank you for your insightful thoughts to share with them. And so, dear team, it was an excellent presentation, and it was very well structured, and also, congratulations for you all, and thank you, sir. If they have any doubts, we can just clear it off.
Yeah. Yeah. Feel
Yeah, dear
free to ask
participants, do you have
if
any
you have any doubts.
doubts? Or else you can just share the feedback. How was the session? And
Okay, one thing before we close, I want to say is that there is a lot of difference between oral morphine and IV morphine. IV morphine can easily cause respiratory depression, but oral morphine, it is a very, 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 very rare event. Okay, oral morphine, to get a respiratory depression, somebody should be actually be suicidal. Will have to take 50 tablets at once, consume it to have a respiratory depression. Okay, because it goes through first pass metabolism, almost, two-thirds of the drug is lost. And for oral morphine to reach a peak plasma volume, it takes about 30 minutes. So there is a lot of kinetics involved in it. So I wouldn't associate oral morphine with respiratory depression, never. It can happen in patients with renal dysfunction, where dose accumulation happens. But for a normal patient who is having pain, specifically cancer pain, it is very, very rare for oral morphine to cause respiratory depression. I'm not talking about IV morphine, oral morphine. Okay. So when you speak to your students, don't communicate this morphine respiratory depression. No, oral morphine is a very rare event. Okay, you will be able to easily catch much before that. When a patient is, taking morphine, if we are giving more dose than required, they will first feel drowsy. Okay, they will just tell you they are feeling drowsy, and you missed it, and then you kept increasing the dose. The next stage is they'll be talking to you like this, and then just dose off in between. They will not be able to keep speaking like how our students do in our class. Okay, while class is going on, they'll just dose off, right? They are not able to keep awake. That is the next stage of drowsiness. Even if you missed that point, next they will be lying down flat and sleeping in case of overdose. But you wake them up, they will get up, respond to you, and then go back to sleep again. They will not be able to keep awake. Okay, that is next stage of drowsiness. The next stage of, even then you missed, you kept giving more doses, they go into a deep sleep, what we call as unarousable drowsiness. We are waking them up, they are not getting up. That is a deep drowsiness. That is when we say it is a toxic effect of morphine. At that point, they are not cooperative. Okay, they cannot swallow anything, drink anything. At that time, you cannot even give an extra dose or more dose. They will come back to the, then because you are not able to give more dose, it will all scale down again. Okay, so that is what I am telling. With oral morphine, it is nearly very difficult to get respiratory depression. Okay, even after the deep drowsiness, patient is on an NG-tube, you give more, then respiratory depression can happen, but you need a significantly more dose from deep drowsiness for respiratory depression to happen. Okay. Only thing we need to be careful about using morphine is in renal dysfunction where dose accumulation happens. So don't associate oral morphine with respiratory depression. That will be a very big misconception. Okay, IV morphine can easily cause because the peak concentration happens within 5 minutes. So that is my last word. I wouldn't say anything more. I know I've offshoot the time. Yes, Hannah, I'm done.
Yeah. Thank you, sir. So, dear participants, do you have any other queries? Okay, so I hope the session was clear and thank you, sir, for the support. And we can wind up. Shall we wind up for today? Yeah. Okay. So, okay. Thank you, sir.
Thank you.